So for all of you that think we have a quiz today, we do not, right? We finished up all our quizzes last week, right? We had our quizzes in weeks 2 and 3. 5 and 6 and 8. Okay, so we don't have a quiz today. We're done. And today is our last day of content. We'll be covering week 9 content in preparation for your exam 3 next week, right? Everybody knows we have an exam next week. I got a message from, I think it's some Centerville students. I got a message from, I didn't receive a message from the students. I received a message from Dr. Connor that she wanted to proctor a couple of you this week. And the exam's not this week.
Yeah, we had to clarify that. She was confused, but she meant next Wednesday.
It's the 14th.
Okay. So with regards to testing on campus, now I have no problem with that, but I need to hear from each student individually if they plan to proctor on campus. So if you are planning on taking the exam, Centerville students, if you're planning on taking the exam next week with Dr. Connor, you have to reach out to me and let me know. I need some form of documentation, and it can simply be an email.
Okay.
And the reason why I need to know that is because I set up a different exam. For if students are taking it in other places, or whether it's online with me, I have to set up different exams. So I need to hear from everybody because I need to assign that different exam to whatever students. Okay, so it's easy. Send me an email, and I would prefer that you send it to me. Today's Friday. I know we have a week. So by next Monday or Tuesday, if you could just send me an email, that'd be fantastic. Okay. So welcome to, I still need a few of you on camera. I can't see Samantha, I can't see you. Lexi, I can't see you. Nina, I can't see you. That's a little bit better, Nina. I know I have a couple of emails in my inbox that I haven't had a chance to respond to yet. I will after class today. Okay, so this week completes our week 9 content. Okay. The exam next week will be on weeks 7, 8, and 9 content. This exam is med-surg, a lot of med-surg. We have those complex chronic illnesses, right? So remember, exams are knowledge to judgment, right? The assumption is you have the knowledge and it's clinical judgment, right? That's what we're being tested on, clinical judgment, being able to care for the clients in the home setting, in the community setting, right? So we're taking our knowledge from all of our classes, right? Again, med-surg, peds, OB, fundamentals. We're bringing it all together in these community exams, and that's what the community HESI is going to be about. So a couple of housekeeping items. So today I want to go through the long announcement that I sent, make sure everybody's clear on everything. In week 9, I like to send out a roadmap, okay, that gives you a feel for all of the next 4 weeks. Okay. I sent, hang on. So we'll go through that announcement. I have a couple of other things. And then we'll go through week 9 content, which is 2 concepts, our final 2 concepts, human abuse and violence, and then cultural influences in nursing. Okay. And then we'll do the case study. We have a cultural case study. And I will break you out into some rooms. Towards the end of class. Room 1 will answer question 1, room 2 will answer question 2, room 3 will answer question 3. And then we'll come back and we'll talk about it. Okay. That's how today's going to go. Okay. So next week, It's busy. Okay, let me pull up the announcement. Oh, everybody should have got the message that I opened the week 11 NCLEX earlier in the week. Okay, so if you want to get it done early, I'm perfectly fine with that because I know week 11 is busy with HESIs. And so there are students that overlook that assignment. Okay, so it is open now. So you can complete your week 11 HESI before week 11. Okay. The other announcement I sent you, can everybody see my screen? Yes, no?
Yes,
Thank you.
yes.
I sent you HESI campus schedules. Everybody see that? Okay, so this is what is on the master roster for faculty of when you're going to be taking your HESI on campus. I like to provide that to you as early as I can so that you can plan accordingly. I don't know if you already know when your other HESIs are, but this is when your community HESI is. Okay. And it is on campus. I don't have anything to do with scheduling. Okay. I'm simply letting you know when your community HESI is going to be. Okay. Your campus, have any of the campuses reached out to you, to the students to start scheduling HESIs?
For the
They sent
Scranton campus,
emails. Yeah,
Pardon me?
they sent emails.
for the
So-
Scranton campus, it's just posted.
Okay,
Um,
fantastic. Okay. Okay, so you should be, if you haven't heard yet, you should be hearing from your campuses in the next week or so, asking you to schedule it. So your scheduling is done all through your campus. If for some reason you're having any issues, please reach out to your campus dean. Okay? I posted early in the week, Professor Ford's exam 3 review. She did that on Monday morning or Tuesday morning. I think it was Monday morning. Okay. So you have that recording. I am doing my exam 3 review after this class at 6 p.m. Eastern. So if anybody wants to, we'll log off at the end of the class. If anybody wants to log back on, I'll be doing my review. Then you'll have that recording tonight or first thing in the morning. And then Professor Kershaw does her exam review Sunday evenings, like she's done the last 2. Could somebody mute that has all the background noise? I would appreciate that. Thank you. So you still have 2 more live reviews to go to. Okay, in your announcement, here's the case study that we'll be doing today. I also sent you in the announcement, if you've had a chance to open it, HESI remediation guidelines. This has not changed since last term or the term before. Okay, everybody knows what these are, right? When you finish your HESI, you have to do remediation. Depending on what your HESI score is, are the required hours to do remediation. I would highly suggest you do, you have to do the required hours, but I would highly suggest that you do all the remediation that you're given, whether it's case studies, rationales. They're very, very, very helpful. Okay, really good learning tools. So you have this now. So that's the requirement for HESI remediation. I just mentioned what the review schedules are for exam 3. Here they are right here. But I also want to point out next week, our HESI reviews. Okay, so you have an exam next week, plus you have HESI reviews. If you can attend, these are in addition to class. Okay. Professor Ford's doing hers on her Monday morning. I'm doing mine on Friday evening. Professor Kershaw's doing hers on Sunday evening. So it's the same schedule for HESI reviews as exam 3 reviews. Okay. Oh, and then the PowerPoint. Okay. I need to pull that up.
Are the HESI reviews going to be recorded as well?
Yeah, absolutely. Absolutely. Yeah. Okay, so let's just go through this roadmap real quick before we start to cover content. There's a lot due this week. There's a lot to think about this week. Sorry, I'm still letting students in. So you have your NCLEX, week 9 NCLEX. Actually, let me back up. There's several students who didn't turn in week 8 work. Okay, no, scratch that. That was for my RN class. This week, you have a lot of things due. You have your NCLEX. You have your HESI case study, the domestic violence and cultural competency. And you have your HESI prep assignment. That is due Sunday. A lot of you have already turned it in, so that's fantastic. And remember, this is going to be your HESI study guide. Okay, and next week when we do our reviews, we use this HESI study guide, HESI prep, to go through as a study guide. Okay, and then the fourth thing this week, if you can, is trying to attend a review. Okay, so that's this week. Next week, we jump right into exam 3. Okay. And same posting of scores will be Saturday. You guys will take the exam a week from today, and it'll be posted next Saturday. Okay. Also next week, your vulnerable populations paper is due. Okay, that's that research paper about a vulnerable population in your community, within your zip code. Okay, and there's a full detailed rubric on what's required. This is an individual assignment, and it's a PowerPoint. Okay, so please go to week 10 if you haven't started this. I hope you've started it, but the rubric is very detailed on what's to be included in your PowerPoint presentation. Okay, and then next week, like I said, we'll be doing HESI reviews. Okay, week 11, just so you know, there is no class in week 11. That's HESI week. Okay, no class. All right. But week 11, also remember that you have the NCLEX questions. If you're not going to do them early, they are due on Sunday. And as of week 11, your attendance is given in week 11 by you simply taking the HESI. Okay? However, homework. I can't accept, after week 11, I can't accept any late work. So if you are late with your vulnerable populations assignment in week 10, you can turn it in week 11 after that, but not after the 7 days. However, if you do not turn in your NCLEX by the Sunday of week 11, I can't accept anything late that week. Does that make sense? Okay, week 12, I want to mention. Remediation must be done no later than Monday night of week 12. That's Monday, June 24th at midnight, or 11:59. If you haven't completed your remediation by then, you end up with a 0 on your HESI. And there's no extensions because grade books are closing on Tuesday. So there's no extensions for that. My suggestion is to get your remediation done as soon as possible after you take the HESI. Okay. Please do not wait till, and the other thing is don't wait till Monday night to do your remediation. You know, if you have several hours to do, let's say you have a computer glitch or your internet goes down or there's something that happens. It matters, but it won't matter with your HESI score. You'll end up with a 0. So just get it done. Okay. For this class, for both of these sections, week 12 attendance, there'll be no class in week 12. Grade books are already closed. All right. So if you would like to get credit for attendance in week 12, you will need to, one or two things. Most students choose to come to an earlier class. You will need to come to my Monday class. All right, so that date will be Monday, June 24th. My Monday class is at 3. You shouldn't have any classes scheduled that week unless you have Monday. Well, you would have, if you have a Monday or Tuesday class, you're going to be required to go to that. But since it's Friday, we have to bring the Friday students up to the front of the week. Okay? This class is at 3 p.m. Eastern time. And it's a very short class. 15 minutes, 10 minutes, 15 minutes. You just have to show up to get attendance. Okay, so if you have attendance issues, and I do have several people in this class that are at 5 or 10%, show up for that class. Okay, we do end of term advising, end of term talking. How did it go? What did you like about the class? What could I improve on as your instructor? Okay, how was the HESI? We talk about the HESI. Did the HESI prep cover what was on the HESI? So it's just debriefing. It's a very short class. All right, so you'll need to attend Monday. If you can't attend Monday and you want to set up a one-on-one with me, it has to be during week 12. It can't be in week 11. It has to be during the week. So it would have to be starting on Monday. And it would only be on Monday. Well, Tuesday, I could do Tuesday, but Monday or Tuesday. We would have to set up a one-on-one to do end of term evaluation.
So for the Scranton campus,
Uh-huh.
we have leadership class on Mondays from 2:30 to 5:15.
Okay. All right.
So that is the Scranton campus.
Okay.
Um,
That's good to know.
which I'm
Yep.
pretty sure all of us are in this class.
Okay. All
Is
right.
Janelle in here as well? I don't know if Janelle's in here.
All right. So I have so I have 5 Scranton students. So what we could do, do you have any class? What time is your class in the morning, or your leadership
No,
class?
nothing in the morning. There's nothing in the morning. The leadership class
All
is
right.
2:30 to 5:15.
And is that East Coast time?
Yes.
All right. So what I might do with this, maybe what I'll do is offer a second class for not only Scranton students, but anybody else who wants to come. Maybe in the morning. And my
Okay.
Monday students are going to come to my Monday class. They know that schedule. But for Scranton students and anybody else who might have a conflict with that 3 o'clock class, I will set up another class in the morning. How's that? Kind of will that help?
That would help the Scranton campus. I can't speak for everybody else. but-
Would that help others too, to give you 2 options on Monday in the morning and in the
Yes,
afternoon?
ma'am. Yep.
Yeah.
Fantastic.
Yes, it will definitely help.
Fantastic. I will do that. No problem at all. I just want to get people checked in and get you credit for a week, 12 attendance. How's that? Okay, that's great to
Thank
know.
you for being accommodating.
Oh, absolutely. Absolutely. No, thank you for letting me know. That's fantastic. Okay. Okay, so those are our housekeeping items. That's a lot of information. Does anybody have any questions? Exam 3, I'll send an email over the weekend. Announcement will be the same setup as exam 1 and 2. You'll be able to download it an hour before. It's the same protocol. Okay. I need to, hang on one sec. I need to jump in and get my PowerPoint, which I forgot to pull up. So, it might be on desktop. So nobody has any questions about any of that.
No, you covered it very well. Thank you.
Welcome.
And I was writing as you were talking, so I do have
Okay.
notes.
All right, fantastic. I can't find my PowerPoint. I'm looking. Bear with me.
You'll send out an email for the earlier class time.
I will. when I figure out, I,
What works for you?
I think, I'm pretty sure I have 2 faculty meetings that morning, so I'll work around that, but I will for sure get something scheduled in the morning. For sure.
Thank you.
You're very welcome. Okay. Where is my PowerPoint? I may have to pull it up from the announcement. Oops. Wait, 9 PowerPoint. There we are. Fantastic. Okay. So let's let me share my screen. Okay. Everybody see my screen?
Yes.
Okay. All right, let's talk about here's all your readings in the first second slide. So we'll talk about human abuse and violence. Real difficult topic to talk about, but we do have to address that since we're going to be working with clients that may be abusers, victims, witnesses, right? And then we'll talk about, I love finishing up with cultural influences of nursing. Very passionate about helping students learn to be culturally competent. I've been doing this for 40 years in nursing, and I'm still not 100%, but I'm pretty darn close. But cultural competence is one of the foundations. Being culturally competent is one of the foundations of our practice. Okay? So when we think about human abuse and violence, what do we think about? What kinds of abuse and violence will we be faced with as caregivers?
Like women who are battered or beaten.
Yep, domestic violence. Hmm. What else, Ryan?
Elder abuse, child abuse,
Elder abuse, elder neglect, child abuse. What else? Homicide. Go ahead.
Financial abuse, exploitation.
Financial abuse, emotional abuse, psychological abuse.
sexual,
Pardon me?
sexual abuse,
I can't say that again, Ryan.
Sexual
You're kind of
abuse.
going in and out.
sexual abuse,
Sexual abuse, human trafficking, homicides, assaults, battery, intimate partner violence, family
No, that's
violence.
just what you're mentioning, like that's just violence. Like that's
Okay.
not types of abuse, like homicide and stuff. That's just
Well,
you're
we're talking about human abuse and violence.
Okay.
Human abuse, we just talked elder abuse, child abuse. We're kind of lumping both of those in together. Family violence. What kinds of family violence might we be forced to deal with in our jobs as nurses?
Family abuse, like
Family
substance
abuse, child abuse, elder abuse, intimate partner abuse. Okay, so
Okay.
we can have individual abuse and violence. We have suicide actually is another form of violence. It's violence against yourself, right? Violence. Violence is obviously a maladaptive coping mechanism. Okay, violence is very common in vulnerable populations. And we certainly have covered a lot of vulnerable populations this term. Okay, think about the increased risks of violence within the homeless population. Think of the increased risks of violence with people who have mental illnesses, have substance abuse issues, alcohol issues.
Yeah, I don't
Okay.
think that's something that we mentioned is like a big one for human abuse and violence is like substance abuse.
Absolutely. It contributes. Yeah, we'll talk about that. Violence is about trying to regain control, trying to regain. Whoops, sorry. Let me mute myself here for a second. Sorry about that. Okay. People, so I'm just going to read from my notes here. These are my lecture notes. People who are involved in violence typically have previous exposures to violence, some form of violence, right? Abusers, they may have been often beaten when they were kids. They may have witnessed one of their parents being abused, one of their siblings being abused. Right? And they tend to learn that violence is a way to manage conflict. Okay? We know that high levels of violence are tied to disparities or inequities. Okay? They're also tied to adverse health outcomes. Think about chronic stress, maybe physiological conditions, obesity, diabetes, hypertension, cancer, hormonal disruptions. As nurses, we all know, right, that we are mandatory reporters. What does that mean?
If you suspect somebody is being abused and or know that somebody is being abused, you have to report it
What in any setting, just your work setting?
in any setting, under
Any setting,
yeah.
grocery store, park, neighbor. We are required by law to report any abuse or any suspected abuse, neglect, whatever.
Yeah, that's big. Like suspected
It's
is
huge.
big. Like it doesn't have to be verified abuse. Like
It's
even if
not up to you to decide whether it's real or not real, but it's up to you to report suspected. That's what family services, child family services, oh my gosh,
DCF or child
DCF,
protective,
that's what these
children
agencies
and
are
youth.
for. People are skilled in assessment, in to evaluate whether this is founded. Usually the words used are founded, not founded. I did a lot of referrals in the schools, a lot. Okay. And remember, whoever is the one witnessing something is the one that needs to report. So I would have teachers or administrators coming to me saying, this child said to me something, or this teacher said something to me about her husband. Can you report that? That's not up to me to report. I can help guide them through the process, but whoever is the one witnessing all of this or suspecting any of it, that is the person that needs to be doing the reporting. And there's significant penalties for not reporting. So we all know that. I hope we all know that.
Yeah, you're just as liable as the person.
Absolutely. So nurses are mandatory reporters of violence against children, elders, vulnerable adults. Okay. Let's talk about the differences between physical neglect and emotional neglect. Okay, physical neglect refers to failure to provide adequate food, clothing, shelter, hygiene, medical care. That's physical neglect. Okay, emotional neglect. That is really the absence of basic nurturing. Okay, think of emotional neglect, basic nurturing. acceptance of a child or a stepchild or whatever. And essentially not providing care for the health and development of your parent, the elderly, children. Okay? Kids who are exposed to violence, they can be victims, and a lot of times they're witnesses, right? They then become much higher risk for mental issues, psychological issues down the road. They are much higher risk for self-harm. They're much higher risk for substance abuse. And they're much higher risk for actually going through with a suicide. We know that abuse is about power and control. All of these methods of abuse are methods to regain control. When we're talking family violence is usually between the most powerful and the least powerful. Family violence is also perpetuated as a cycle, so generation to generation. So as kids grow up seeing violence in their home, however, it looks like parents with kids, parents with parents living in the house, other relatives. Okay? Violence in the home can be used as a method of control over the environment. Whether you want to control the whole family, whether you want to control a spouse, whether you want to control a kid. Okay? Kids being exposed to violence, they are much higher risk for violence in their own relationships as an adult. Okay, think of all the disparities in risks. So family maybe living in poverty, living with financial struggles, maybe dealing with a crisis, maybe an unintended pregnancy, unemployment, loss of a job, marital strain, divorce, death, so many other reasons. The risk of violence or abuse goes up. We saw this with COVID, social isolation. Remember all those parents that either needed to quit their job and stay home, or parents lost their jobs, or kids were at home alone without school. Social isolation highly contributes to violence. Okay, the less social support, social gatherings, social interactions you have, the higher at risk you are. Elder abuse is a type of family violence. All right, there's several kinds of elder abuse. Physical abuse, emotional abuse, financial abuse. And I'm sure we could all cite examples of what we may know about, have been exposed to, have seen, maybe in our own personal lives, but also in our work settings. Elder abuse is increasing by the numbers year after year. So what are some symptoms? Victims of violence exhibit symptoms. Let's talk about kids. Kids prone to frequent headaches, stomach aches, bedwetting, regression, anxiety, depression, withdrawn behavior, maybe inappropriate sexual behavior or knowledge. Maybe they become precocious during puberty. Lots of issues, and I saw this day after day after day in the schools with these kids. They exhibited all of this. Or different situations exhibited all of these behaviors. Women who are abused women, prone to chronic headaches, palpitations, sleep and appetite disturbances, sexual dysfunction, even irritable bowel syndrome, IBS, recurrent UTIs and vaginal infections. Abused women actually increase more miscarriages, preterm births, and low-weight infants. And we do know that abuse does generally escalate during pregnancy. One other type of violence is intimate partner violence, or intimate partner, take it a step further, intimate partner homicide. One of the biggest risk factors for intimate partner homicide is that there's been previous domestic violence issues between the two people. Partners, husband, wife, spouse. The other risk factors for intimate partner homicide: access to guns, access to firearms, maybe estrangement issues, maybe threatening to kill you or somebody with a weapon, trying to strangle. This is all about intimate partner homicide. Non-fatal strangulation episodes. So, oh, go ahead.
Sorry, I'm a little confused with what you mean by intimate partner. Like, obviously, is that a person you're in a relationship with,
Yeah.
or like,
Yeah.
okay, so that's always going to be like a girlfriend, husband, wife. That's what
Or
intimate partner
partner.
means.
Partner. Whatever the relationship is. You are it is what I'm talking about with intimate partner homicide is whatever partnership you're in.
You don't have to be straight to kill somebody, Ryan.
Saying is it's like it's what do you call it? It's a relationship that is built around like attraction and love for what, right? It's not like me and
Intimate.
my father. Okay, because you could be close to your grandma. Like, so you just mean it like intimate.
I understand what you meant, Ryan.
Intimate, more like someone you're in a relationship with.
Well, the top, yes, the topic I'm addressing is intimate partner homicide. So I don't think that would be you and your grandma. That would be who you're in a relationship with, however that looks. Right? That, I think what you're talking about, let's say you, your grandma, or your stepmom, or your stepdad, that's more of family violence. I would put that into the category of family violence. Intimate partner homicide, intimate partner violence is specific to whomever you are in a intimate relationship with. Does that help?
Yep.
Okay, fantastic. When we suspect any kind of abuse, right, we always have to be open-minded, right? We need to let them tell their story. We need to be non-judgmental. We need to give people, whether it's kids, adults, elderly, we need to give them the opportunity to report without feeling guilt or shame. That's a big issue. A lot of people don't come forward with the reporting, right? Because of fear or guilt or shame. And if you have at-risk adults, let's say you have parents that are already at high risk. Okay, don't have a lot of resources. Don't have a big support group. Maybe they have other mental health issues, depression, anxiety. Let's say they have past issues with abuse. I'm talking about parents now. With all that factored in, those parents have an increased risk to actually abuse their own children with everything going on. Let me go back to elderly. Elders are at risk of any kind of violence, physical, emotional, financial, as well as neglect. Here's some examples. Emotional abuse may include demeaning or saying things to affect the elderly person's self-esteem. Maybe it's name calling. It's trying to scare them, embarrass them. Maybe it's destroying property, not letting people see their family or friends, isolation. Maybe they're afraid of abandonment, right? That if they don't do what they're supposed to do, you're not going to, not you, but somebody's not going to take care of them. Financial abuse. You always have to be mindful of that. You know, it could be a family member or a close friend that all of a sudden takes over their finances. You know, of course, if they're not competent to take over their finances or to continue with their finances, of course, somebody else will have to look into that. But what if you have a competent elderly person, right, that's still doing all their finances, and somebody comes and steps in and starts doing everything, family member, friend, puts them at high risk for financial abuse. Think of all the things we hear out in the world about elderly patients getting scammed, elderly people getting scammed. Right? So as a nurse, we're advocates. Advocates, I was the advocate for our kids in the schools. If you're working with the elderly, you're their advocate. We're advocates for whoever we're caring for, so we have to be mindful of that. So I'll speak from a school nurse perspective. What did I do? What did I do as a school nurse? Okay, I worked with teachers and administrators to recognize abuse. I did seminars and programs for parents about how to have good coping skills, how to manage personal and professional lives. And this could go for anybody in the community could be doing this. Anger management programs for parents, for kids, recognizing bullying, harassing. Did a lot of that in the school. Home visitation for families that are at risk for violence and abuse. Did those home visits. So there's lots of things that can be done. Okay. Guess I should be following along with my PowerPoint. Mandatory reporters, follow-up counseling for children. I think that was one of your quiz questions about making sure. Was that one of your quiz questions? It was, if a child witnesses violence, maybe that was a previous exam question. What's the first thing? What's the priority? And the answer was trying to get them into counseling.
That was a quiz question.
Okay, quiz question. Abuse is about power and control. We talked about that. Family violence between the most powerful and least powerful. Symptoms, victim, we talked about that. Talked about intimate partner homicide, elder abuse. Okay. Does anybody have any questions about human abuse and violence? We are going to be working with clients. We are.
Question.
We may be working with clients who are perpetrators. I had a student tell me when I first started at Fortis, one of the first or second or third term I was in Fortis, we were talking about this. And we were talking about taking care of how difficult sometimes it can be to take care of perpetrators of violence, right? But we're also taking care of victims, or we'll be in contact with victims, with witnesses. I had a student tell me that She worked in a correctional facility, right? Her sister had been murdered. And the person who was sent to prison for murder had health issues that had to come to the correctional clinic. This was the person who murdered her sister. And anyway, they worked out a scenario, but she was morally unable to care for that person. And then that brings up a whole nother sort of issues with ethics, right? That story has always stuck with me. All right, let's finish up with culture.
Ryan, did you have a question? I thought Ryan had a question.
Ryan, does Ryan have a question?
Sorry, Professor.
No.
So you're saying, like if a question was presented where it said, what would be your priority, getting a child out of a situation in which he's being he's being abused, physically abused. You're saying that getting him into counseling or getting him into a counsel situation would be priority
No.
over.
I think no. The question on the quiz, somebody can probably pull it up, was I think it was if a child has witnessed abuse, what should be the priority we would do? And that would be having them talk to somebody, get them into counseling. Your question of if a child is being abused, what's the priority there?
Get them out of that situation.
Get them out of that situation and report
Save
it.
that child.
Right. Does that make sense, Ryan? So I think we're talking about two different things here.
Yeah, so that would be the case for any type of abuse. Our first priority is always if they're the ones being abused, getting them out of that situation.
Well, first and foremost, you need to report it. Right? As far as getting them out immediately, that's not, well, that's for DCF to figure out. Right? We're not going to hold a child at school at 3 o'clock when the bell rings because we suspect abuse. Right? I mean, does that make sense?
I have a question as well.
There has to be more than just a suspicion. You have to have like physical evidence kind of that.
Well,
or you have to.
In a lot of these cases, well, in the schools, when we're making reports and we have high enough concerns maybe about physical abuse or sending this kid home at the end of the day, we'll have the resource officers come. And they're able to hold the child at school until the assessment is done. And I mean, there's a million different scenarios, but what I want you to remember is we are mandated reporters. We do have to report incidences of neglect and abuse. Okay. And then each case is handled case by case. If it is not safe, if the administrator, the principal, I'm just speaking with the school nurse, deems it is not safe for the children to go home, they will get the police involved. Many times when child social services shows up at the school, the police are already there. Kayla, go ahead.
Okay, my question is, so say for instance, you have a child, it could be an elderly person or anything like that. And say for instance, you file a report on abuse or whatever the situation is. So if you follow back up with that person, they pretty much say nothing is done. You try to, do another complaint about abuse or something like that. Is that something that you could continuously keep doing if you feel, or if they're saying they're getting abuse or anything like that?
And a lot of times, Kayla, I'll speak from my school nurse perspective, we were 1,000% sure that something was going on, and it turned out to be unfounded. Whether that's true or not, it didn't proceed. So there were many cases where something else happened, would report it. Something else happened, report it. Then you start to see a pattern. So it is not guaranteed. And that's the frustrating part as a nurse. And that was one of the most frustrating parts where I knew something was going on. I did my due diligence and things didn't change. The child was not removed from the home where my opinion would have been differently, but it wasn't up to me. Very, 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 a lot of cases where it was just hard to swallow. Right? Does that answer your question?
Yes, ma'am.
It's a very delicate topic, abuse and neglect. It happens in all forms to all different people. Everybody has their own opinion, but all we can do is not all, but what we can do as healthcare workers and being advocates for our clients, whether they're in the home setting, in the hospice setting, long-term facilities, rehab facilities, we have to do our due diligence and report if we have concerns. That's was one of the hardest things for me in my school nurse job, was trying to advocate for these kids and knowing I can't count the number of days I went home or the nights I went home with a bellyache, knowing that that student was going back into their home situation. It's
And or
hard.
worse because somebody
Par-
reported.
Pardon me?
And or worse because somebody reported.
And that's the other thing too about reporting. It's you report and it's anonymous. Like the family services cannot say to the parent, Kathy Marvel reported that your kid told her this morning that he was beaten up before he went to school by his dad. They can't disclose that. That is federal guidelines. You can't disclose that. Now the parents, of course, all the time jump to conclusions. Oh, it was the school. Oh, it was my terrible neighbor. Oh, it was the terrible nurse at the school who's always calling me about sending medications in. Right? I mean, there's always plenty of blame to go around, but they can't disclose who made the report.
No, they're not going to disclose who made the report, but you also get the other end of it of when that kid comes home, and if that kid is being beaten,
Exactly.
you get that other end of it of that
Exactly.
kid is going to be beaten again for the parent might thinking, well, you went to
Probably
school or
worse.
something.
Probably
Yeah, they're
worse.
getting it worse. Yeah. Like,
It's-
well, I beat you this morning and then you decided to go to school to say something. I'm going to get you again.
Yep. Yep. Yep.
And that's
It
just the reality of it.
It happens all the time with kids, with the elderly, with couples, partners, domestic violence. I mean, if you think about the big picture, look, just all you have to do is turn on the news any night. I try not to anymore. It's full of violence, stories of violence. That's it. I mean, it's so disheartening. Or just our culture in general and the violence in our culture. And as healthcare workers, guess what? We're on the front lines. Right, Kayla? Kayla's shaking her head. We are in the front lines. We are going to be exposed to this. There is no way around it.
Nope.
There's no way around it. So, it's hard, but it's part of our job. And we have responsibilities. Okay. Let's talk about culture. I love to say the cultural competence for my last concept to talk about. What's cultural competence? What is it? Come on, guys. What is cultural competence? What does it mean to be culturally
Having the
competent?
understanding of other cultures.
Okay, that's a good start. Thank you, Christina. That's a good start. What else? No, that's a great start.
Using that understanding, in kind of perceiving the way that they might want to go with their healthcare, but also know that like the patient is, every patient is different, but it at least like kind of gives you a direction to go and have a general understanding of what might want to do.
Great. Great addition to what Christina said, Ryan. Keep going. There's
So
plenty more.
I believe that we need to learn our first to understand other ones.
Udelka, you need to understand your culture first before you
Yes.
can okay, great. Fantastic. What else?
Not having a prejudiced or biased opinion, like she was
Perfect.
saying, not being prejudiced or biased or having your own thought on a different culture or not thinking that your culture is above anybody else's culture or that
Perfect. That's
superior.
awesome. Who else wants to add to that?
I was just gonna say maybe like respecting their beliefs, although like someone else said you might not agree with it, but at the end of the day, this is your job, so this is what we have to do.
Perfect. Great. You guys are doing great.
Mhm.
Anything else to add?
Just just developing the communication and interaction techniques that are, respectful and effective. Along with that, just valuing the diversity of others. That's how I look at it.
And
That's
everybody is unique.
That is
Exactly.
perfect. That is perfect. You guys rock. Rock. So we know culture is everything that we believe to be true about the world. Every one of us are from different cultures. Every one of us have our culture, every one of our cultures has different values, beliefs, practices, preferences, assumptions about certain things. Okay, we are typically born into a culture. So throughout childhood, we are molded into the beliefs and practices of that culture. A lot of cultures have a lot of similarities, but a lot of cultures have very big differences. Right? We are all unique. We all grew up differently. When we think about different cultures, we think about things like language, the sense of touch. Some
The
people
space.
some people like to hug, others hands off. Personal space, is that what you said, Udelka?
Yes.
Personal space,
Eye contact.
eye contact, body language. What about perceptions of health and illnesses? Maybe different cultures handle end of life care. What
Yeah, a lot
about
of them do herbal like remedies instead of like doing medicine.
Absolutely. Right? So that's the perceptions of health, right? How do you cure a headache? What about visitors in a hospital? Who can visit, who can? Who males and females and taking care of specific clients? Preferences, childbearing practices, reproductive rights, time orientation. Is a certain culture past focused, present focused, future focused? What else? What else varies in cultures? That's pretty
Food.
common.
Food.
Food
Culture.
preferences, nutritional preferences, healing. What else?
Clothings.
Pardon me?
Clothing on what they wear.
Clothing.
Like
Absolutely.
some people wear headscarves and
Exactly.
or jewels on them.
Yeah. So the
And
point,
like
the
they
point
won't go to the
here,
operating room without it.
absolutely.
They
What about Jehovah's Witnesses who don't accept blood transfusions?
Question about that. So if you just got a new patient in and the patient was to the point where they didn't like they couldn't talk or speak or anything, and you didn't know that their religion was that, and you went ahead, or not us, of course, because we're not a provider, but they went ahead and gave this person blood to save their life, would they get in trouble for that, although they didn't really know that?
Well, they should have known. I mean, that's a pretty out there scenario, but I don't know if they get in trouble for it, but you would have to go back and do that quality that investigation. Why didn't we know about it? Was it an emergent situation, a life-threatening situation that there was no time to find out about it.
Most
I'm
people
just throwing my
love-
thoughts out there.
Most
Or,
people of Jehovah's Witness wear band, they wear
Yeah.
medical bracelets and stuff like that, saying they're of Jehovah's Witness,
yeah,
because of how important it is that they do not
Mhm.
receive blood products.
gotcha.
So they
I
have.
guess it would
a
depend on the
necklace-
scenario, Kayla, of what was the current status of the client? I mean, you could say the same thing about, I mean, there's lots of cultural beliefs that are forbidden, right? And so I just threw that out there as an example. What if you have a I'm just throwing these out there. What if you have a Jewish patient and their food tray comes up and it's full of kosher? Or no,
That would be a good thing.
pardon me?
That would be a good thing if they're Jewish and it's full
That's
of
what I
kosher.
mean. What if their tray was served, it was a non-kosher diet? What if a Muslim patient had a tray come up that had all pork products on? So that's where we have to stay ahead, right? So my point is we have to know the cultures we're taking care of. Are we expected to know everything right now? Absolutely not. I have been learning about different cultures for 40 years. I consider myself culturally competent because I will have the motivation to learn about a new culture if I need to. I will seek out the information about the culture if I'm not familiar with it. I will do my own research. I will talk to kids in the schools. I'll talk to parents. Right? It's cultural desire, right? As nurses, we have to have the desire to be culturally competent. Because if we don't have that desire, that's where things happen, miscommunications, mistakes, misunderstandings. Okay? We need to approach clients, every single client, as a unique individual. Okay? We learn the culture through observation, through assessment, through asking questions. Right? We must avoid being judgmental, stereotyping, being biased. So we go back to that old thing we learned a couple of weeks ago, which was you got to check your own feelings first, right? You've got to check your own beliefs about different cultures and their practices. Got to check all that. Make sure you're feeling culturally competent and wanting to take care of clients of different cultures. Got to check your own stuff. Right? The other thing we need to remember about being culturally competent, well, let me just read this to you. I love this. To develop cultural competence, you need to be sensitive to cultural implications during each encounter. Avoid stereotyping based on race, ethnicity, or ethnicity. Ask questions to stimulate our learning about the client's culture. Avoid making assumptions about maybe nonverbal cues from clients from unfamiliar cultures. Nonverbal cues may be totally innocent, right? So we're always trying to make ongoing discoveries about new cultures. That's a priority for our nursing practice, right? We use the families, we use the friends, however we can obtain information about cultures. And most importantly, we can't think that our culture, I think Christina might have said it, our culture is not, my culture is not better than yours, right? It's not. That's one other thing I was going to say. So when we're dealing with different cultures, let's say there's a language barrier. We always want to try first, the best tool would be an interpreter. Right? Let's say we're dealing with a non-English speaking immigrant population or a population that doesn't speak English, right? Interpreters are the best. That's our first line of defense. If not, maybe we can ask family, friends. Maybe a coworker is part of the same culture. And most importantly, since we're in the community, we have to find out, seek out whomever in the community can help us out. Let's say you have a Vietnamese, and I say that because I had experience with this. Let's say you have a large Vietnamese population in your community that doesn't speak English. Well, where is the Vietnamese population located? Do they have a place where they gather? Do they have a church where they gather? Do they have a place, a park they gather? Right? Do they have people in the community that are Vietnamese leaders that are helping them? Those are the people you have to seek out. Remember, community nursing is teamwork. So we've got to seek out those trusted leaders. Maybe a coach of a kid's team. Who knows? A religious leader, a community leader. And this goes same with the immigrant population, irregardless of immigration status. Okay? There's going to be barriers. There's going to be cultural barriers. There's going to be language barriers. Again, find the team members that you need to sit at the table with you and help you get to that population, whether it's about enrolling in school, about immunizations, about elderly resources, Meals on Wheels, whatever that community resource, whatever's needed for that population. You got to seek out the people in your community to help you. Does that make sense? We shouldn't be looking at any two individuals in the exact same way. Okay. One of the things I did in my Monday class, but I don't think we're going to have time because I want to do the case study, is we went through, I had like 20 students in my Monday class, and we went through and talked about examples of your interactions with different cultures. It was a fantastic discussion, about really how students had taken care of different people from different cultures and how they tackled it, how they approached it, how they learned about it. And every student had a story. Every student had a story. Right? So I would encourage you to think about that. We're not going to go through and do that because I want to do the case study, but I would encourage you to think about it. I will guarantee you that every single one of you have already in your healthcare journey taken care of clients from different cultures. Is there anybody who hasn't? We all have. And we're all going to continue to do that throughout our entire career. Right? So we have to be open-minded. We have to be open-minded and accepting. I know what I want to mention. As nurses, as we plan care for our clients from different cultures, we must try our best through the whole healthcare team, doctors, nurses, pharmacy, food service, environment. We must try and incorporate as much of the culture, values, beliefs, practices, preferences. We must try to incorporate as much of their culture into that health plan, into that discharge planning, into that case management work. Right? Questions about cultural competence. It's one of the foundations of our practice. You're going to be caring for people, interacting with people of different cultures. You already have in the past, but going forward every day.
I feel like it's a very, very broad topic.
I know. Well, cultural competence is a broad topic, but if you start to break it down for different cultures, there's things that we need to look at with each culture, like we talked about, all the different things you guys mentioned, language, what's acceptable, what's not, How much can we use in the plan of care? Yeah, cultural competence is a big word. I mean, we have to be culturally competent in our own personal lives too, not just our work, right? Our kids are going to school with kids from all different cultures. You're working with people in your work settings from different cultures. We have patients from different cultures. It's everywhere. It's all around us. Right?
Yes.
We may have healthcare providers, doctors that we see, practitioners, PAs that are from different cultures. It's embedded. It's embedded in our lives. It always has been. However, because our society is so diverse now, and even our country is so diverse, our communities are so diverse, our schools are diverse, our long-term care facilities are diverse, our workforce is diverse. Different cultures are embedded in every part of our lives, right? Okay, I'm going to assign you guys, it's going to be 3 big groups because there's only 3 questions. I want somebody in the group needs to pull up the case study in the announcement. This is a cultural competency case study, and it just reinforces everything we just talked about culture. So I'm going to do my breakout rooms here. How many do I have? Whoops, I need to do one more. Close all my rooms. Start over. I didn't do it right to begin with. Add a room. There we go. Okay, here we go. I'm just doing. We get a lot of students. Okay. I think you'll like this case study. Okay. Oh boy, what did I do here? Okay. So we'll spend, what time is it? 5:15. Spend about five minutes. 5 minutes in the breakout room. You guys come up with your answer. Room 1, answer question 1. Room 2, question 2, 3, and then we'll come back and talk about it for 10 minutes and we'll be done. All right, so I'll see you in a minute. So join all your rooms, please. Samantha, you there? Quintia, can you join your room?
I tried to. It brought me back here. How do I go back?
I'm sorry, you should have an invitation to join. Samantha, you there?
I'm pretty sure she'll close the breakout rooms too.
Your name is Callie, right?
Yes.
You said you was in Capstone earlier.
Yeah.
Is that how your school particularly do it? Like you have community and Capstone together or something, or you just chose to do it that way?
No, unfortunately, they put leadership, capstone, and community all in one mod.
Oh wow. Ours is mental health, leadership, and Capstone in the semester.
Mental health, leadership, and
Having community, leadership, and capstone in the same mod is extremely difficult.
I can imagine, especially like with the side work you got to do for pretty much everything.
Right. Because like there's so much to do with leadership and there's so much to do with community. Like we have a lot of papers and a lot of projects and stuff that are due for both of those classes.
but think about the clinicals you don't have.
no, we
that
have
is true.
clinicals
In what?
For men,
Okay,
well, you don't
for-
have mental health.
for
Capstone, right?
capstone. We have clinicals.
Right?
Yeah, but it's nice to only have one class that has clinicals. Like we're in
Exactly.
peds, med surg too,
Yeah,
and community. And we have
exactly.
clinical for both peds and med
So
surg
there's,
too.
I usually have a combination of students. One group is either community, capstone, and leadership. The other group is community, peds, and med surg. And they all have clinicals.
Oh,
Yeah. Yeah.
no.
I just want to ask a question to someone other than Scranton campus. Are any of you guys are any of you guys in the last term or so in
I
Scranton
am.
campus? Okay, what
Nina,
courses do you have?
It
I'm
depends.
taking
It depends.
mental health, community leadership, and
Yeah.
capstone.
Oh, 4?
Yeah.
We've never had 4 classes. That's crazy.
Some
they won't
students
give
have-
us
well-
4. Yeah. Oh,
But every
more
student
power.
has
We've
every
had 4
student has
plus.
different scenarios. So
Yeah,
not every
I've
student,
noticed-
but yeah.
I've noticed that some like I know we have to go back to the thing like we have 6 like modules, like some places have 5.
Hmm. Hmm.
I couldn't do
Yeah.
5. I don't know what I would
Every
do, but
school's
that's
a
good.
little different. So
Exactly. Exactly.
and I think we're all just realizing that. Like we're all just realizing other
Yeah.
schools have like a little bit of a different curriculum.
Correct. Correct.
Yeah, I have much.
But I will say, everybody's busy with whatever
Yeah.
track you're on with whatever classes. This is
This
a
is
killer.
busy week.
This is a killer term.
Yeah, it is.
It is.
Tell me about it.
It's
I,
not
I
fun.
know. I know. I know. But you guys are great. I've really, I know this has been a big class, 2 sections. I've really enjoyed this class. Really enjoyed it. And I hope you guys have learned. Hope you guys have expanded your knowledge about community nursing. We tend to think of community nursing as home health visits. And it's so much more than that, right?
Yeah.
Have you guys learned a lot in this class?
I
Yes.
mean, when I first started, I really couldn't tell you what community nursing was.
Mm-hmm.
Like in a general, like I couldn't even like
Right.
community
Yeah.
nursing because like
But-
I think of more like home health aides, not really
Exactly.
home health nurses.
Exactly. But think about it. And I said this in week 1, and we're going to do the case study because I am going to get you out on time. We said this about in week 1. When clients leave an acute care facility and need follow-up care, it could be a kid going back to school, had an asthma exacerbation or anaphylactic reaction, they're having EpiPen, whether it's kids going back to school, whether it's somebody who's had a stroke going back home, whether it's somebody who had a stroke that's going to a rehab, whether it's an elderly that needs assisted living long-term care, whether it's somebody going to the urgent care, whether it's somebody needing dialysis, hospice care. Who do you think takes care of these clients?
Community nurse.
Community nurses. Community
Well,
nursing
It's
is
never a thought in my head though. Like it was
I
never a
know.
thought like
no
who took care of people after they got
right.
discharged from the hospital.
And yeah, I mean, it's the difference between acute care setting and providing care in the community. Many people need care in the community, whether it's in the schools, whether it's in a hospice center, urgent care, medical office building, rehab. People, you know, you don't tend to think of long-term care facilities or memory care places as community nursing, but it is. It's care being provided outside the acute care setting.
Hi, wait, I want to, wait, can I ask Nina a question real fast? So when you do capstone, they didn't say that community was a prereq for capstone, like you couldn't do capstone until you did community? They didn't say that?
No, they never said that.
No, I think it is actually.
Oh, wow. Yeah, they let me take it. So
It must be nice. Must be nice.
No, it's a lot.
Oh, maybe Nina's getting special treatment. Let's not start that discussion. Let's not start Nina's getting special treatment. Okay. All right. So we have Nancy. She's a public health nurse working in a clinic that provides services to the community of Hmong immigrants. Right. So these immigrants who are applying for visas, they're required to go through a medical screening. Okay, primary purpose of conducting these exams is to determine the presence of any kind of communicable diseases, to vaccinate according to CDC guidelines. Okay, she is typically the first person to initiate contact with the new immigrants. She does not speak the same language as individuals who report to her clinic, but she has access to an interpreter. She's aware the clients are nervous about seeking care because they are unfamiliar with U.S. healthcare practices, which most immigrants are. Unfamiliar with practices. So group one, room one, did you come up with the answer B?
Yes.
Yeah.
Okay. Yeah. Public health nurses providing service to recent immigrants should be most priority word, most concerned about which of the following. What does our case study tell us? What's the first thing we need to be concerned about? Being knowledgeable about high-risk diseases of the population.
Right.
Let's look at the rationale. Nurses need to know if there are specific risk factors for any given immigrant population. Here's some examples. Southeast Asians, they're often at risk for hepatitis, TB, intestinal parasites, vision, hearing, dental issues. And most of these conditions are preventable or treatable if managed correctly, right? So here's a teaching reinforcement. When working with immigrant populations, consider how your background, beliefs, knowledge may be significantly different from those receiving the care. Language barriers may interfere with efforts to care for them or provide assistance. We need to understand non-traditional healing practices that clients or certain cultures use. So that reinforces what we just talked about. So Ms. Chang, the nurse, she speaks English and Chinese. She's dealing with new Hmong immigrants who speak Laotian as their primary language, and they're unfamiliar with our practices. How is cultural competence demonstrated in dealing with the population? Did room 2 select B and E?
B and E, yes.
Yes.
Perfect. The nurse provides care while paying attention to individual beliefs about pain, touch, modesty, and eye contact. That's what I meant when I said incorporating their beliefs into their plan, into the health plan. And that the nurse provides care that acknowledges the differences in ways individuals respond. That reinforces our teaching that every culture has a different way of looking at things. They have different ways to respond to illness, different ways to respond to treatment. That's being culturally competent. Okay, culturally reinforcement here. Culturally competent nurses function effectively when caring for clients of all the other cultures. All right, let me read that again. When we are culturally competent, that means we can function effectively, meaning we can care for clients of other cultures. Nurses who strive to be culturally competent respect people from other cultures. They value their diversity, and this helps in providing competent, more responsive care. So cultural competence includes acknowledging the fundamental differences in the ways in which clients and their families respond to illness or treatment from what might be your thinking of how you may do it, right? And we talked about some examples: dietary, pain management, death and dying, modesty, eye contact, closeness, touching. So the nurse now goes out and attends a local class at the local Laotian Cultural Center so she can learn more about customs and practices of the community she serves. What is this an example of? Did you come up with D? Group 3?
Yes, we come up with D.
Great. And here's it. This rationale is a nice summary of the differences between A, B, C, and D. Desire, skill, awareness, and knowledge. So cultural knowledge is information about different elements of diverse cultures. She was seeking out knowledge going to this, where did she go?
Yeah.
Cultural center.
Yeah. The
Okay,
first
so-
question give you the answer for the last one.
What? Say that
The
again?
first question of the of this, it give you the answer for the last one.
Mhm.
Everything was knowledgeable.
Yep. Emphasis for a cultural knowledge, you're trying to learn about the client's culture, their worldview from their perspective, right? Having an understanding of the client's culture decreases misinterpretations, misapplications, miscommunication. Okay, that's knowledge. Desire, cultural desire. You have to have the intrinsic motivation to want to learn about different cultures so that you can provide culturally competent care. That's our desire. The skill. Cultural skill means that you can effectively integrate what you know about the culture into their plan. So you have the cultural skill to care for them. And then cultural awareness, that simply is the self-examination and exploration of our own beliefs and how our own beliefs influence our behavior as we care for clients of different cultures. I love that case study. I really like it. It just reinforces everything. Did you guys like the case study? Yeah. Okay. All right. I am gonna stay on time here. It is 5:29 and we're done at 5:30. So if anybody has any questions and wants to stay on, I can do that. And then remember, I'm doing my review starting in 30 minutes. All right. So everybody have a great weekend. Reach out as you're preparing for exam 3. You don't take it till next Friday. You have all next week to reach out to me if you're struggling with any concepts. After you go to a review or listen to the recordings, you'll have them all by Sunday night. If you're still struggling as you're preparing for the exam, reach out to me next week. Professor Marvel, can we jump on Zoom for 5 minutes? I have a couple of questions. Of course. Of course. All right.
Bye. See you at 6.
All right. Bye, everybody.
Bye.
Bye.
Have a great weekend.
You
too.
too.